Good morning, everyone. Hello. Welcome to Medicaid Business Transformation DC Value-Based Payment Learning Collaborative. Medicaid Business Transformation DC is a technical assistance initiative funded by the DC Department of Healthcare Finance. The session is titled Revenue Cycle Operational Excellence, a Foundation for Value-Based Payments, and will be presented by Luana Lepole, Brianna Jacob, and Todd Husty. The Learning Collaborative session recordings and slide decks will be posted to the Medicaid Business Transformation DC website, along with additional value-based payment resources. Please feel free to add questions for the presenters in the chat box throughout today's presentation. Here are our presenters. I'll first hand it off to Luana to introduce herself.
Good morning, everybody. Thanks for having us. My name is Luana Lepole. I'm a principal consultant with HMA, Health Management Associates, in the Minneapolis, Minnesota office. I have a background in the payer market with United Health Group, United Healthcare, National Network, and Value-Based Care, as well as a background in the provider side of the business, running large service lines like neuroscience, oncology, radiology, imaging, and cardiology. I also have a background in public health. Glad to be here today. Thank you. Brianna?
Good morning, everyone. Brianna Jacob, Senior Consultant here with HMA. Like Luana, I have a lot of decades of experience, mostly on the provider side, with over the last 10 years being in behavioral health. Started my career in revenue cycles, so started out on the finance side of things and had transitioned over to operations a number of years back, being the CEO of a psychiatric facility. And so very much looking forward to this discussion this morning. Dr. Todd Husty.
Thank you very much, Brianna. So my name's Todd Husty. I'm an elderly ER doc. I'm 72 years old, but I've been around in healthcare for a long time. Started a company called Marcy Medical Audit Resource Services, Inc. about 30 years ago, which primarily focused on documentation and coding. But in that, it also focuses on quality. And they all can go, and I will show you that they do go hand in hand. We joined forces with HMA about a year and a half ago. It's been a great joining. But I'm really clinically oriented. Obviously, I still do a lot of clinical work, but I look at administrative things through the eyes of the providers and of the patients. So thank you for having me.
So continuing education credits for social workers and continuing medical education credits will be available for this session. To be eligible for continuing education credits, you must participate in the full session. So you have to stay for the entire time. To request credits, please complete the online evaluation. It'll be shared via email, and I'll also have a link for it for you guys at the end after today's session. Certificates will be emailed to participants in about 10 to 12 days. And I will now turn it over to Brianna to kick off this presentation with the agenda.
Yes, good morning. Thanks, Dan. So today our agenda, which you see on your screen, is an overview of the revenue cycle and how the revenue cycle really has an impact on value-based payment models and the reimbursement that you receive from those. So we're going to explore a few key performance indicators. We're going to go over some operational best practices and then show the intersection with how they are linked to value-based reimbursement and what's to come with value-based reimbursement. So the learning objectives, which were outlined during your registration process, will discuss the impact of operational excellence and revenue cycle management and the technology infrastructure that goes with it. And then also demonstrate how to align the payment model with quality metrics. Next slide. And so with that, you'll see a question on your screen. In value-based arrangements, if providers perform well on blank, they get enhanced reimbursement. And you should see a poll pop up. So if everyone will select their answer, please. All right, we'll give everyone a second to get those answers in. All right, so it looks like 87% of you answered E, all of the above, with obviously the other 13% on quality. So I'll take those results. The answer is E, all of the above. All of those are factors in what we know to be the outcomes of value-based, but quality is also a very, very good answer, as well, as that is always our focus in healthcare, or should be. Next slide, please. So with that, why are we talking about this today? Value-based care and value-based payments is a relatively new delivery model in which providers, hospitals, everybody's paid on their health outcomes. It's intended to support the delivery of evidence-based practice, of person-centered care, of quality care, of all of the things that lead to positive and efficient outcomes for consumers. And so with value-based care, there's a lot of different people that we are considering. What is the value add? Healthcare payers and policymakers have made a series of advances incrementally towards this, with CMS leading the charge. Moving people away from fee-for-service value-based into more meaningful value-based arrangements. And so who does this benefit, right? I think it benefits a number of people and impacts a number of people throughout this. And what they're looking for, the value they're looking for, can be different. So for patients, they're looking for lower costs, they're looking for better outcomes, they're looking to be healthier at the end of the day, right? For providers, we're looking maybe for higher patient satisfaction rates and more effective care, or the ability to maybe lower costs a little bit in providing care. Payers are obviously looking for stronger cost controls and reduce risk across their entire patient population. Suppliers might be looking for an alignment of prices that are parallel to the patient outcomes themselves. And then society as a whole is just looking for reduced healthcare spending and better overall health. And so while we keep in mind the object of value-based care in this discussion today, we're going to think about all of the people that are trying to get value out of this process, and how do we work towards that from a revenue cycle and operational kind of perspective. Next slide. And so with that, there's a few important considerations, what I will call overarching considerations, that we're going to talk through today. One is the infrastructure investments and how do you govern it? So what kind of investment is it going to take in your practice to implement value-based care? What type of infrastructure do you need to build? How are you going to govern this model? How are you going to hold yourselves accountable? Long-term planning. What does this look like? What does the next 6 months look like? What does the next 12 months look like? What does the next year, 2 years, 5 years look like? What kind of clinical transformation and practices do you need to put in place? Documentation, auditing, any training and education components that need to be considered. And then what kind of standards and benchmarks are you going to track and measure? The challenge, I think, with value-based care is that there's a number of benchmarks and standards out there. Which of them you track to and which of them end up in your value-based agreements can look very different from practice to practice, or even payer to payer. So figuring out what you do well and how do you get that into an agreement, and also what maybe do you need to improve upon, and you need to be monitoring that in case it does end up in an agreement. And then also looking at the technology and infrastructure you have and your capacity to utilize and analyze data in real time. which historically sometimes is a challenge to get data out of EHR or dashboards in a real-time fashion. So we're going to talk through a lot of this today in smaller, but these are the 5 areas and domains that we really think need to be thought through now, knowing that incrementally as we get across the next 5 years, it's going to be increasingly important to be prepared for this. So as we go through the next set of slides and we start talking through this stuff, I want you to keep in the back of your mind, are we ready? Are we ready in this topic? Is this a strong point for us? Is this something we should work on? But always keeping in mind kind of assessing your practice on your organization to say, are we ready to do these things? Next slide. And so again, looking at contracting and collaboration is going to be key. Understanding your arrangements and your contracts, making sure all of the staff understand the terms that you are held to and how all the different pieces need to collaborate in order to be successful under these models. How do we optimize the staffing, both revenue cycle and all of the staff as a whole? You have a lot of technology, in fee for service, you might have claim scrubbers and coding reviews that you need to consider. Will that be the same under value-based? Do you need additional staffing? Do you need different staffing? Do you need to retrain or educate maybe non-clinical staff on some components? And then again, the data and quality. Success under VBC really does come down to quality and understanding and reviewing your metrics. And so again, these are all things that we're going to kind of explore a little bit further today, and making sure that everybody is understanding of how you can prepare for these things. What are the questions you should be asking yourselves now? And what things can you be doing today to get these things in place? I know some of you are looking to move to electronic health records and practice management systems potentially here in the next few weeks to few months. And so what things should you be considering now as you go into those scenarios or into those engagements that help you plan and prepare for the future of value-based? Next slide. And so with that, I'm going to turn it over to my colleague Luana to talk through the contracting and collaboration piece.
Great, thank you, Brianna. So next we're going to talk about contracting and collaborating with the provider teams as well as the payers in the market. So the next slide, please. So we will start out by having you share your knowledge about value-based care. What payment model is not an example of value-based care? Cost-based reimbursement, risk-based payment, fee-for-service, and capitation. Give you a little extra time here. If everybody's submitted now, we can take the answer. Okay, we had 69% for fee for service, which is correct, and a cost-based reimbursement, 19%. All right. Fee for service is the answer. So fee for service has been a standard for a very long time in our market, but things are now changing toward pay for performance and basically risk sharing contracts. Fee for service has had many cases led to overuse of diagnostics, tools, treatments, performance of procedures, and higher volumes in general, and ordering means that we're going to have higher reimbursements, but we're moving away from that now. Cost-based reimbursements are based on garnering percents of total costs, which are determined specifically by the contracting payer. Rural CAHs typically have these kind of payments arrangements that are based on costs, and it's quite rare to find them outside of the rural space with the critical access hospitals. Risk-based payments overall are included in the risk-sharing models, and it's based on a per member per month fee that's paid out for quality and clinical outcomes and access as well for patients. And the provider and the payer share in the bottom line savings of a program. Shared savings programs are becoming very popular. They're also pay for performance on clinical and quality. Bundled payments basically are a fixed price agreement for a predefined episode of care, such as psychiatry or a procedure, commonly consisting of the fee as well as all related services that are included in the care for that particular patient and their condition. Capitation is a fixed cap fee per patient for a subset of patients to deliver all care. Capitation creates incentives for physicians to minimize services provided to patients and to attract large numbers of patients to their panels, which sometimes results in shorter office visits. MIPS is also something to be aware of. MIPS is a merit-based incentive plan for meeting quality benchmarks and has become very popular. It includes 4 things, which is ER use, EHR use, quality, resource use, as well as clinical practice improvement overall. Next slide, please. Contracting. So it's important to know the rules of your contracting arrangements with your payers, you know what's expected of you and how are you incentivized. Basically, who? Know your payers. Who are they? What are their contract stipulations overall? The attributed member groups and beneficiaries, patient groups, and also the provider groups that are involved in these particular programs. What performance metrics and measurements, both clinically from a quality perspective and financially, are required? How? To what degree are the standards and benchmarks met for these metrics and measurements and financial outcomes overall? And when? When are the performance terms? What are the deadlines, report cadences, and the protocols that are required within? So it's very, very important to understand your contracts and if they differ between payers for these programs. Next slide, please. Revenue cycle, value-based care. So value today is really based on quality and cost, high quality patient outcomes and experience, patient experience scores, as well as keeping your direct costs and indirect costs down. Quality patient outcomes are paramount, as this is the patient experience. Willingness to recommend and is really important to your patients coming back and feeling like they're getting good clinical care, being tended to, having great attentiveness by their providers, et cetera. The direct costs that we pay are basically labor and benefits, capital equipment, associated disposables, supplies, genetics, and lab tests. And indirect costs are typically rent, utilities, IT, things like that. It's definitely a new world now, and the train has left the station, so I'd say it's best to be on board. Value-based care is here to stay. You can see the comparative columns here for volume and value-based care. Value-based care and ACO overall approach the whole healthcare organization, working toward collaborating and coordinating their care. Chronic care management is another way of coordinating care for Medicare populations that have chronically ill patients. That means 2 or more chronic conditions and having seen a doctor within the last 12 months of their experience. And I think that this is going to move toward all patients overall. Right now, chronic care management is very, very big in the Medicare market, but really all patients with chronic conditions, 2 or more, ought to have their needs met at a very high level. It's about 72% right now for the Medicare market that qualify as chronically ill with 2 or more conditions, which is it's very, very high. Part of that is because the percentage is high because they've increased the number of diagnoses and conditions that actually fall within. But it's very important to manage the high-risk patients because they cost the system a lot of money and they also need a lot of clinical care and attention. So we want that to be efficient. We want to manage the patient holistically with annual wellness visits, case management, which is the top 2% of patients with severity, chronic care management, as I just mentioned, and of course, behavioral health, social determinants of health, access, flow, follow-up. These things are all critically important. And the ultimate goal really is prospective, predictive, and preventative healthcare for all patients. Next slide. Contracting. Oops, I'm sorry. Optimizing revenue cycle. So in summary, this slide and visual shows the transition from fee-for-service to value-based care, wherein the fee-for-service includes high number of visits, diagnostics, testing, procedures for a resulting higher reimbursement. Performance-based incentives include pay-for-performance models, primary care patient-centered medical homes, and episodic care with associated services wrapped up for a fee. And finally, the transfer of risk or risk share programs that include ACOs, value-based models, and per member per month fees and shared savings dollars to be split between the provider and the payer, which requires a lot of responsibility for the solid care of each patient. and most certainly is our healthcare future. So really the focus now, it's best to focus now. I actually heard Elizabeth Fowler at a Minnesota Hospital Association meeting recently mention about 5 times during the meeting that by 2030, all Medicare patients were going to be on an ACO and a chronic care management program, and that it wasn't up for choice anymore. So we have about 6 years to fix that. But at the end of the day, all patients, Medicaid, Medicare, all patients will be managed with value-based care. So it's important to get on board overall. Okay, thanks so much. Brianna, I'll turn it over to you now for slide 15.
Thank you. And so again, I think that collaborating with the payers, aligning your goals, all of that is one piece of the puzzle. The other piece of the puzzle is the staffing and the optimization of your staffing in order to be successful and efficient under value-based. Next slide, please. And so value-based requires an interdependence of payment reform and the way we get paid. But at the same time, it requires practice redesign. It requires us to think differently about the way we do the work. And so practice transformation without a financial model is not sustainable. At the same time, payment reform without practice transformation doesn't change the overall outcomes. And that could be the outcomes in the financial model, that could be the outcomes for the patient. It just doesn't change. One piece does not change the whole thing. You need both pieces of this. Next slide. And so part of that, again, is staffing. It is the key to being successful. And so here you will see this lovely figure related to all the different pieces that surround the patient throughout their healthcare experience, starting with the registration when they call an organization to get scheduled for services, how the front desk staff handles the information coming into them and the registration of the patient. How does the patient get triaged? What kind of assessments get done? Is there any pre-visit planning or paperwork that is included? Is telehealth a factor in your practice? For some of you, that is more of a likelihood than others. But I think, again, telehealth is here to stay. And so we have to figure out how the workflows accommodate for that. Is there a care coordinator in your organization or perhaps a wellness coach? Do you provide behavioral health services? Is there a social worker? Do you have somebody who coordinates care with outside practices related to maybe transportation or housing or food insecurity? And then obviously the office nurses and medical assistants that assist the providers. All of these people are staff that the patient and their families come in contact during a healthcare interaction or event. And so it's very critical that we identify what the roles in the organization are, what the responsibilities are, and what impact they have on the outcomes. And so I'll give you an example of that. You know, you're registering a patient when they call to schedule. How far out is your next appointment? How easy is it for that patient to schedule an appointment with you? Is it easy? Can they text? Can they call? Do they get somebody who answers the phone right away? Do they have to leave a voicemail and you call them back? All of that influences the patient experience and potentially the patient outcome. You know, perhaps they call your practice and you leave them on hold for a long time. That may impact them actually showing up for care. That may impact the patient experience. And so it's critical in understanding all of the roles and that they do have an impact. And where does the handoff and the intersection between the roles make a nice continuous process for the patient? And how efficient is that handoff? Are there redundant tasks in between these roles? The other thing to keep in mind as you're evaluating your staffing under VBP is making sure we're using staff to the top of their scope. Are your providers or your physicians or your advanced practice practitioners, are they potentially doing a lot of administrative tasks that could be done by somebody else? Is your social workers, performing all of the potential assessments and interactions that they could be doing? So all of this is key to make sure that your staffing is efficient. Make sure that you're evaluating everything that each role is responsible for and making sure that you're using those staff at the top of their scope. It makes it efficient. It does help with cost savings. And then you'll find frequently that the workflow may have redundancies in it. And so how do you accommodate for those and fix those? And is there some technology that you can layer in with staff that will be helpful as well? And so you'll really want to take a good look at the staffing as you evaluate your going into VBP. The other thing you won't see here on this figure that's still very important is all of the things after the patient experience. And so how does the claim get coded? Who audits the documentation? How do claims get submitted? How does the payment and reimbursement get received? Those are all also very critical to this. And so it's important to keep in mind that even what we call the back end of the revenue cycle, or all the things that happen after the service is completed, those are still very important and need to be very efficient in making sure that everybody understands the importance of their role. And everybody keeps in mind that they have to be very patient-centric in their approach to their role. Next slide, please. And one of the things that we have seen a lot in value-based care is what we call the daily huddle, or sometimes in hospitals, you'll even hear the term care conference, right? Making sure that both the provider and anybody who's part of the care team huddles for the day. They talk about what patients are on the schedule for the day, which of those patients are high risk, which of those patients are more likely to call in or no show for the appointment, and are we preemptively reaching out and contacting those patients, noting any patients who've had hospital visits recently or are coming as a follow-up from the emergency department, and how do those need to be handled, and making sure that all of that is captured and that all of the things are done. Going through any results or referrals needed for the day, any patient-specific issues. Maybe you have a patient who has called and already said they're coming in late, or for some reason they're having this major issue that maybe wasn't the original cause for making an appointment, and how can that be handled? This is also a good time to look at the scheduling for the day, and we'll dive into this a little bit later in the conversation. But what does the schedule look like? Do you have open holes today where maybe you could call patients that are on the schedule for next week and get them in early? How do you handle no-shows? Do you have a way of backfilling those? Do you have maybe a clinician or a provider who's called in today, and so you're trying to move their patients around to be seen still by somebody else? Did you have a patient who came in and maybe stayed a little bit longer than you thought they would, and so now you're behind for the day? How are you going to catch up? Do you have an ancillary staff who's out for the day? Maybe you don't have a receptionist, and so the phone's not getting answered. All of these things are really good topics to meet and huddle in the morning and kind of work together. I think throughout all of this, the biggest thing to keep in mind, it has to be a team model. It has to be collaborative, and everybody is very, very critical to being successful in this model. The other thing to discuss is any safety issues. I know a lot of times I come from the behavioral health world, and so knowing how you're going to handle those, knowing what the potential for those are, and making sure that you discuss those. So I think the daily huddle is one of the best practices that we've seen, both, on an inpatient basis and outpatient basis and everywhere in between. It's just very conducive to that team model and making sure that you are creating a patient experience that is worthy of great outcomes. Next slide. And so as we talk through all of those things and we talk about what a daily huddle might look like, the key to a good daily huddle is the ability to have information at your fingertips. So this screenshot is, an example of an operational dashboard. And for those of you, again, who might be looking to implement an EHR or practice management system here in the near future, these are things to consider, functionalities like this. What tools do you have at your disposal to look at things in real time? Whether that be the number of visits that are on the schedule for the day, the number of patients who've checked in for those visits, the no-show rate for the day, as a practice or by provider. Also, are you able to accommodate any same-day appointments, and how do you track that? What is your next available appointment window look like? Is your next available appointment tomorrow? Is it next week? Are you scheduling 6 weeks out? All of those things are important operational metrics. And again, we'll dive in a little bit deeper to this later. But the key here is, if you are creating this team model and you are having the daily conversation about it, what tools do you have to support and give you the data to discuss? And so this is just one example of some real-time things. You can see what the average time to be seen is from the moment the patient checks in to the moment they go back and see the provider. What does that wait time look like? Is there a way that you guys can streamline things to make sure that you can maybe bring that wait time down a little bit? And then looking at things over time. So one tool that you can use is looking at this on a day-to-day basis, whether that's in your team huddle, whether that is from a leadership level, but then also looking at it over time from a month-to-month perspective. Do things fluctuate? We all know they do, but having the data that actually visually tells you, okay, Mondays are busier for us. July is a slow month. We have less visits. We have more no-shows. So knowing all of that lets you plan your resources accordingly, which only makes your cost savings or efficiency all the better. Next slide, please. And so with this is another dashboard. As you begin to get more advanced payment models and they begin to evolve, more advanced dashboards are typically necessary. The one that's up here now is very much looking at it from a PM perspective or per member per month perspective. Where are you trending? From a population health for each defined population of patients, how many do we see? How many of our patients have chronic health, chronic heart failure? How many of our patients are diabetic? Of those, how many times do we see those particular patients? Do we have a particular subset of patients who are more likely to either cost more to provide the care, or maybe they disengage from care more than others? And so there are some dashboards out there that are very, very helpful in terms of looking at things from a more population level perspective and really looking at what does your provider or your patient panel look like for your practice. And so dashboards like these are helpful as you get into more advanced patient or payment models, because really you're looking at the performance of the practice, right? You're looking at patient engagement. You're looking at your coding compliance and accuracy. You're looking at population health type of stuff. And then also looking at the cost and revenue data as well. What is it costing you? If you know how much you're taking in per member per month, what does it take you to provide that care per member per month? And so all of these are considerations as you're evaluating vendors and systems and tools to be able to forecast out and trend some very important data that you will need to be looking at throughout value-based payment. Next slide. And so where does all of this data come from? Where does it start, right? It starts with the patients. It starts when the first phone call is answered for that patient to make an appointment with you. And so how do you address incoming referrals? Do you get referrals via fax? Do you get referrals just from phone calls? Do you get referrals directly from health systems? And what data do you take in at that point? And so one of the key things here, and we've talked a little bit about how do you, the data you need from an output perspective, but how are you getting that data? So one of the things to look at in your practices would be, how do we get the referrals? What information do we take in at that point in the process? How quickly can we schedule? How do we document? So making sure that the staff that are receiving these referrals and scheduling these appointments, what types of information are we requiring that they complete? Are the fields in the system required where they have to complete them? We all know sometimes if the fields aren't required that they get bypassed. And so making sure that you're looking at all of the demographic and health information and how can you get as much information and confirm the accuracy of the information as early in the process as possible. And so making sure that the systems are set up accordingly. Do you have enough front desk staff to answer the phones in a timely fashion? Are they trained on customer service techniques and how to ask the questions to get the data? And then are they entering the data into the appropriate places in the system where it's easily digestible later on in the process, right? We all know we schedule an appointment, we show up for our appointment, and we're given a demographics form to complete on paper. So we complete this whole demographics profile on paper. What happens to that information? Does it stay on paper? Does it get entered into the system? These are all things to think through, because again, if we're collecting that information on paper, but it never translates into a data grouping, whether that's, in your EHR, your practice management software, or in a standalone tool, then how do we get it out later on in the process? How do we use that data that we have taken in? Next slide, please. And so again, looking at the check-in process, we've now scheduled the patient. They're coming in for the appointment. They've arrived. They're checking in. We're giving them the demographic and registration forms. How are we getting that, making sure that that information is entered into the system and that we're copying the insurance cards and the idea and that we're explaining things? I think that's a crucial point to make is we've talked about the fact that value-based is based on outcomes and that patient experience plays a role in this. So as you're asking the patient to complete these demographic and registration forms, and you're asking them for information like their copy of their insurance cards and their identification, how are you setting the expectations with the patients related to this information? Are we telling them why we're collecting it? Are we explaining our policies and procedures? Are we explaining that, we're running a little bit late today, or, the provider has called in, but we have another provider here for you to see? All of these steps in the process are very crucial because, again, they are helping to paint the picture of the patient experience. And so we want all of these different links in the chain to be a positive experience for the patient. So is there a way to streamline the demographics form? Can we do it digitally on the tablet? Can they do it ahead of time before they come in for their appointment? Are we make it easy for them to have a copy of their insurance cards and ID? Did we tell them when we scheduled them on the phone that they need to bring their insurance cards and ID? And then are we explaining the policy and the wait time and where they are in the process once they're in the building? All of this wraps up into a customer service, patient-centered patient experience that we want to be really, really useful. The other thing I will say here is you've got this all in the system. You've scheduled the patient. How convenient is it for the patient to be seen, right? And how are you conveying that? Making sure that your scheduling blocks are up to date in the system, making sure that if you are booking a few weeks out, that there is a very particular customer-centered way of relaying that to the patient. All of these things are going to be critical. And then also, do you have a way of maybe calling them to come in early if they are booked 6 weeks out and now you have a cancellation? And so all of this data getting into the system, making sure it's accurate, and then making sure that you can reach back out to those patients to really close the loop on some of this is very important. I'll also say making sure that you validate information. So all of this on the screen really talks about that first engagement with the patient, but also we need to look at how do we verify that every time they come in thereafter? And do we make it easy to do so in, you know, a good experience for the patient, but also making sure that we have accurate data in the system. Next slide, please. And so the role of the front door is really, it is critical. And sometimes I think it's more critical than people give it credit for. You know, we focus a lot on coding and we focus a lot on how you get a clean claim out the door at the end. But we cannot lose sight of the fact that the front door is very, very important function, because you gather so much information, right? You are identifying who they're going to see. You're identifying all of their demographics, all of their health concerns. You have to obtain pre-authorization and certification when necessary. You might need to obtain orders for particular tests. You need to obtain consents. So it is the patient's first interaction with the organization. And it's also the linchpin for a lot of data. And so making sure that, again, you are evaluating every position, and you're also evaluating all of the training that that position receives, right? Do they understand? Does your front desk staff understand the importance of the data that you are asking them to collect in the patient experience, in patient outcomes, and in the financial outcomes as well? Really making sure that your team understands and is trained for all of the things that start here. And then also making sure that the rest of your staff on the back end of the process understand the importance of the front desk. And so sometimes it's, oh, well, the front desk doesn't really get involved in this, but the front desk is very important. And so making sure that everybody understands their role and understands the importance of the role next to them as well. I keep coming back to the scheduling and making sure the scheduling is efficient and making sure that the scheduling is smooth. But part of that is also that could be a metric under value-based, right? So you might have a agreement and time to next appointment or time to be seen as your metric. That is why some of these things are very important to do, not only because of the patient outcome, but because these are potentially metrics later on down the road as well. At the end of the day, I think the importance here is that everything matters. Everyone in the process matters. And does everyone understand their role and the next role and the flow of the patient care being provided? Next slide, please. And so these are some performance indicators you can track as it relates to the front desk and the front door. Patient registration goes by many names across the industry. What is your daily visit total versus what is the expected visit total, right? How many appointments did you have scheduled for today, and how many patients actually showed up and took those appointments? And what is your percentage of visits? Again, looking at it on a monthly basis, what is your monthly visit utilization and how does it fluctuate from month to month? We all know there are certain seasons of the year that could look very different. And how do you toggle your resources to match those and to understand those trends? Chart audit check in advance of next appointment. How many practices are actually looking at the patient schedules and the charts of the scheduled patients prior to the date of service? How many places are verifying their insurance before the patients arrive? All of these things are performance indicators that we recommend, considering. Call answer rate. People value this very differently. Some places will look at ring totals. Did you answer the phone prior to 3 rings? Did you answer the phone in 30 seconds or less? Call abandonment rate. If you have a more involved phone system, you can look at a lot of metrics related to your calls. But when a patient calls, can they get to you? Can they get to you quickly? And can we start the process for service quickly? And then also comprehensive member assessment plans, the benchmark being 90%. Are these plans completed? Are they up to date? And making sure that you have all of the things that you need to provide the care across the visit. And so how are you going to track these, right? Like, these are great metrics, but do you have the information and can your system provide the information to you to be able to get to these metrics very quickly and in a real-time fashion, right? It doesn't really do you much good to look at your total daily visit total and your expected visits 6 weeks from now. So how do you get that information? Can your system give it to you at the click of a button? Or does somebody have to manually track it? And that takes a staffing resource, but really thinking through how would you track these metrics and how easily can you track these metrics so that you can make operational changes in real time that impact the patient experience and also potentially the cost impact to the organization. Next slide, please. And then here's some other examples of metrics that practices could take a look at. You know, do you have a patient portal? If your patients use the portal, if they do use the portal, what things can you put in the portal to make their experience easier or better? Do you have consents in there? Do you have, can they upload their card and their ID? Is the registration forms in there? Can they pay their bill through the portal? All of these things impact the patient experience. Again, we talked about no-show or cancellation rates. Are you tracking that? You'll see some metrics here of kind of what you see across the couple-year period for cancellation rates. And then the percentage of appointments rescheduled within 30 days. So again, looking at the reschedule rate, I think certain specialties have different rates for reschedule, but also do you have particular patients who reschedule frequently? And then how do you use your staff or your team to try to engage that patient into services? So working more efficiently, engaging with the patients in an efficient manner, and making sure that you utilize all of the tools at your disposal is really going to be critical as you move into value-based care. Next slide. And so while you're looking at the staffing, obviously we want to look at training, right? Fostering a culture of learning and collaboration, getting creative with staffing and figuring out who does what and what the handoffs are, providing them with feedback and recognition. The road to value-based has been a long one for healthcare as a whole. But even for organizations, you know, some of this practice transformation it's not overnight. It takes time. There will be obstacles to it. And so really providing that feedback and recognition and allowing the staff to provide the feedback as well. And so potential training opportunities, and these are not just for staff that we would normally consider to be revenue cycle staff. These will not hurt any of your ancillary or clinical staff to hear as well. So what is the financial consequences of registration errors, and providing some examples for maybe missteps or areas of opportunity? How does the staff discuss reimbursement matters with a patient? This one is a big one. Words matter. And so the framing of feedback to the patients related to their balances or their insurance, or maybe their insurance lapsing, how do you expect the staff to communicate consistently? And can all of your staff do it? Can the front desk staff do it? Can your clinical staff and your providers do it, as well as your billing staff on the back end, right? How do we discuss these things with the patients? I cannot overstate the importance of making sure your policies and protocols and any contract changes that may be impacting care are communicated to the staff timely. Contracts tend to live over in their own area. And so how do we make sure that when there's a contract change, or maybe there's a new metric that is included in a contract, what is the process to make sure that translates into policy, and then translates into protocol, and then translates into training? That is very big, and is often an area that is missed, is those changes that happen annually or sometimes even quarterly. How are they transitioned all the way through to making sure that the line staff understand the impact to their role? What are some denial prevention and management techniques? This one again is pretty big. How How do we prevent a denial? For the front desk, preventing a denial might be look like getting accurate information, the correct insurance, the correct date of birth, making sure that if there's a pre-authorization necessary, that is communicated. From the clinical and provider staff, right, that might look like accurate coding and documentation. And then from the billing staff on the end, making sure a clean claim goes out and everything is in the appropriate location and that we're not missing any fields. And all of those are very important, and each role has a role in denial prevention. Denial prevention is not just a billing or revenue cycle function. Denial prevention is on everyone. We always recommend the basics of revenue cycle management training for all staff. I think doing this annually and at new hire can be very helpful. Again, just showing the collaborative teamwork model that revenue cycle requires, and also that sorry, lost my train of thought. Also that there are roles in revenue cycle for everyone, and that it is everyone's responsibility for denial prevention and for the efficiency of the workflow. A lot of that can be captured in a revenue cycle basics training. Obviously, documentation and its impact on reimbursement. I know we have another webinar series later this afternoon that focuses on documentation and coding, but this is huge. Not only for your clinical and provider staff, but for any of those that have a coding or utilization management staff as well. Documentation cannot be understated here. And so all of this is important. Looking at how your staff do these things. Is there opportunities for cross-training your staff in certain areas? But overall, these are all potential trainings that you could put in place. I will say the other thing for staff training is, do you have easy guidance and easy reference tools for your staff to use? Especially as you're going into documentation and coding. Do you have desk aids for staff? Do they have the appropriate tools that they need? All of these are components both to staff satisfaction, but ultimately to making sure that your staff also have translate that into a great patient experience as well. Next slide, please. And so we've talked a lot about staff and the importance of all of the roles they play. And we talked some about the way data comes into the system, right? So that importance of data collection, that's getting the data from the patient, it's the staff taking that data and then putting it into the system in a particular fashion. And I think that as you transition from fee-for-service into value-based, there's a couple layers there, right? We've always collected some level of demographic data from the patient. But now we're looking at that more from a population health perspective, right? Or maybe an SDOH perspective, right? Are we tracking their veteran status? Are we tracking race and ethnicity or language preference? Are we tracking if they have, transportation issues? All of that type of population health data, we continue to see more and more the importance of gathering that information and putting it into the system. And so those will be increasingly important. Obviously, diagnosis and service code data is important. For those of you who may have access to claims data, that is also helpful to take a look at, right? Quality metrics. How are you tracking your quality metrics? How are you disseminating that to your staff? How are you using it to make decisions? But there's other operational things under value-based that you you may not have considered up to this point. So how are you translating your cost and revenue data on top of your patient data and the population data to really make decisions? Are you tracking operational type data? Are you tracking your time to next visit? Are you tracking your cancellation rate? Are you tracking provider schedule optimization type data? And then again, with that enhanced data, are you tracking veteran status? Are you tracking homelessness status or, food insecurity data? Any of that enhanced type of demographics that you could get from the patient. All of that type of data will be very helpful in painting a patient diagnostic picture, but also a patient panel population type picture for your practice, right? And so as you look at this and as you're looking at your systems and the ability to gather this data and translate it to a usable output, starting to think both at the patient level, but then also at the practice level, right? What does my patient population look like? What is the cost to provide services to my practice population look like? And how are we taking all of that data that we've gathered and making decisions that at the end of the day increase positive patient outcomes and reduce cost outputs where possible? And so what data do you get? How do you collect it? And can you get it back out of the systems in a usable fashion? That way you can make real-time decisions. At the end of the day, it's understanding your population and making your decisions based on that. Next slide. So with that, I will turn it over to Luana for metrics and outcomes.
Thank you, Brianna. So as Brianna mentioned, data is critically important. We'll go to the next slide, please. For metrics and outcomes, it's very important to understand how you manage your data entry and how the system captures the data that you provide. And of course, the output of data for reporting, how you secure that so you report to your leadership. This table shows you here some categories and elements within that can be utilized in a value-based program that can be a snapshot and data reportable for your program. The IT system that you use really matters for the collection, storage, and retrievability of data, of course. Fast retrieval of aggregated data, efficient querying, reporting, and analysis of data too. And of course, developing and building data systems based on the contract requirements as needed. That's very important. Amidst all these different elements you see within, there are also some other useful operational metrics, which is like days to the first available appointment you want to focus on, your third next available appointment, which is actually a more sensitive reflection of your true availability, because oftentimes cancellations can result in your first next available appointment. Your follow-up, some of this is repetitive of what Brianna mentioned, but your follow-up for appointments within a certain X number of days, your cancellation and no-show rates and paying attention to those, very, very critical to add to this pillar, these pillars here. There are a number of elements for a best practice value-based program, all of which can be quantified. So it's important to note that anything that can be quantified becomes data and then becomes entered to the system, retrieved, and then reported out. And good value-based programs actually include a number of things: an annual budget, having an annual budget and a forecast for the program within, utilizing a robust EHR system, improving your patient access overall at all levels, as Brianna pointed out, providing care management for all of your high-risk patients. This keeps your quality and clinical results and outcomes high and your costs down overall. And really, at the end of the day, like Todd Husty says, we want to develop the best care for our patients. The costs will be kept down if we're providing the right care. So it really is focused on the patient. Reduction of avoidable hospital admissions and of course readmissions, which is a big issue, especially with transitions of care. Reduction of emergency department utilization, and in some cases even urgent care. Addressing behavioral health overall and social determinants of health is very, very important nowadays. It never used to be, but it is now. It's becoming very, very important as elements of best practice organization and across the continuum, focusing on the patient experience, quality, and patient satisfaction. And I might also add in there provider satisfaction, which is part of the quintuple aim now. Patients can sense if providers and non-clinical people in clinics are not, enjoying their jobs. So it's very important that our people have a quick in their step and provide great service to our patients. Also utilizing data to improve care, using app-based communications when you can, telehealth, telemedicine, remote patient monitoring, of course, for efficiency and real-time patient checks and balances are all part of the future. Practice patient provider shared decision-making is very important. We have to include the patient in the decision-making that's incurred based on their diagnosis and their prognosis. And also we want to focus heavily on net promoter scores, Press Ganey, SurveyMonkey, customer satisfaction surveys, because at the end of the day, we really want to know what our patients think of the work that we're doing and the services that we're providing to them. Next slide. Revenue cycle management. Oh, next one. Yeah, there we go. Nope, back. Thank you so much. Patient access. Patient access in terms of open phone lines and centralized scheduling is critical to the practice. Some of the reasons you might want to use a centralized scheduling system is to improve your provider utilization and have more efficient operations, as well as reducing your wait time overall, which is very important to the patients, obviously, and their families. Optimize appointment schedules. It's very key to providing availability for new patients and returning patients and follow-ups as well. You want to have full optimized schedules by day, by week. This translates to faster reimbursement. I always say that reimbursement today is better than the possibility of reimbursement tomorrow. We want to keep patient wait times low in every phase of their journey. Quality throughput results in charges being dropped sooner and higher patient experience scores overall. So if we think about what it is that we're doing on the operational and clinical side, it translates into throughput, streamlining, results, dollars later, and actual happier teams as well. We want to obtain authorizations. That's very critical. If an insurance company states that an authorization is needed, we must always obtain the authorization. Very important, but it gets missed too often. No-shows, appointment cancellations, and appointment rescheduling management is very, very important to keep the full day, the full weekly schedule. We always want to rebook patients real time if possible. And if not, put them on a short list to reach out in the near term to reschedule them. Also, it's important to have your patient wait list handy to backfill for cancellations real time. Patient registration. Very important to collect all of our co-pays, our co-insurances, our self-pay balances in dollars at the point of service locations when the patients come in. It's always amazing to me how often people are ready to pay if you just ask them. That might sound very simple, but there's a lot of groups that don't ask. And if you don't ask, you won't receive. So just asking, it really will increase the dollars you receive for self-pays, co-insurances, and co-pays. For registration, we want to keep that at about 2.5 to 3 patients per hour. This includes all demographic information, insurance verification, and discussions about collecting co-pays at the time that they arrive. We want to keep our patient call wait times very low if possible, and make sure that our phone trees are effective. Very big frustration to patients, huge frustration to patients, as is parking arrangements. We also want to look at our net promoter scores, of course, and the scores of willingness to recommend your practice, because this is what patients are looking. They're looking at you when they're at the practice. They're seeing how things flow. They're watching how they're treated, what their first interaction is. Brianna went over this when she talked about the front desk. That is their first point of contact, and it's just so important to give them the best friendly service possible and to meet all their needs and to follow up timely. People really appreciate it. They notice it, and it will reflect in your willingness to recommend scores for your practice. And also we keep top of mind the risk adjustment factor scoring. This is based on predicted costs by diagnosis. So if the diagnosis is higher or more acute, there are higher associated reimbursements as well. So it's very important for us to know where we stand with the risk adjustment scores by patient and health condition. And in revenue cycle, we need solid clinical data overall, obviously note-taking, charting within the right 24 to 48 hour windows that are slated, decent provider coding, and if there's education needed for the providers, we should offer that, utilization of modifiers, and of course, clean claims data, getting that to 98% if we can. And of course, keeping a focus on our risk adjustment factors overall, as I said before. Next slide. So here's some revenue cycle benchmarks. The target for days in AR is typically 35 days, and factors typically include a charge lag, which is how quickly the notes are closed, sign-offs are obtained, and the charges are actually dropped. An expected charge lag is about 2 days or less. As I mentioned, the collection rate is 95% and the clean claim rate is 98%. The denial rates, we always want to keep denials down less than 5% if possible. We want to keep bad debt write-offs below 1%. 0.5%, less than 0.5% is even better, actually. Pre-registration rates, we want to have at 100%. It's very important to get your pre-registrations correct on the front end. Insurance verification rate at about 98%. And as I said, bad debt less than 1% or 0.5%. So these revenue cycle benchmarks are important to hit and to remind yourself of in the revenue cycle team, because they really show that you've got a robust practice on the revenue cycle side. And of course, operationally and clinically as well, because it does involve the doctors, being involved with their notes and solid charting and coding, et cetera. So I'll turn it all over now to Todd Husty, Dr. Todd Husty, for the next slide, which is coding. Todd?
Thank you very much, Luana. I've been having problems with my camera. It's been going on and off, so I'm not sure if you're going to be able to see me or not. I might just turn it off. So some of what I have to say, maybe a lot of what's on my slides, you have kind of heard from other viewpoints. I'm going to do it a little bit more from how does that affect us clinically? I mean, pure clinically. So the first thing that I always say is that the goal in value-based reimbursement is to prevent the diseases you can. Then the ones you can't, you need to find all the problems and diseases the patient has. Then you need to, and that might include diagnostics, get the testings you want, get the consultations that you need, but don't get one of everything for everybody. Get the ones you need. But the real goal is to keep them out of the hospital. Wait a minute. Prevent disease, find the diseases, take really good care of them, and keep them out of the hospital. That is why I went to medical school. And that is actually how this system works, because the majority of the revenue that goes to pay for the patient care, including paying for us to take care of them, for the office staff, and everything that was said about office staff in this is extremely important. But to pay for all that, to pay for the hospitalizations that are necessary, and then to pay for the payers have some administrative oversight also. They have to get paid. And then it'd be nice if there's a little bit of money left over for people to split up. Indeed, it was mentioned in risk-based contracts is that even the providers participate in the money left over. So how do we go about doing that? I'm going to hit some of the points at the top from the healthcare delivery, the quality part. And then I'm also going to tie that in with parts of the efficiency. And then I'm going to go back into, so how effective is that? So yeah, preventive medicine and wellness care, of course. I mean, it goes without saying, although it is a quality measure, that is a place where in many systems, there's actually extra revenue that comes in by showing that you've done those things. We should be doing it anyway. Vaccinations and screenings, chronic care monitoring, tests and treatment. So that's after you've already determined that the patient has a chronic condition, but it's extremely important. It goes down to, if you go to the efficiency box, the appropriate use of the emergency department, inpatient, and ambulatory surgical centers. So I'm an ER doc. If you send me a patient because you haven't been able to see them and they're saying, I feel a little funny today. And you say, well, you better go to the emergency department. There's a good chance, because I don't know the patient, that I'm not going to take risk on that patient at all. So I'm just going to put him in the hospital. Cha-ching, cha-ching. So that costs a fair amount of money, It is usually the largest expense in the healthcare budget per capita. So it's huge. It really eats up the money that's out there. So the goal is to find, just above there, it says validating suspect conditions. So we're looking for everything that the patient has, and I mean everything. We also need to document that. That's in the middle box, is talking about coding. But you can't submit it right or to the payer if it's not coded right, or you shouldn't, and you can't really code it right if it's not documented right. So what is good documentation? What does that look like as a clinician? And it's actually very simple. Find the diseases and look into your suspected conditions, get the tests you need. But when you determine they have a condition, that needs to be documented, number one, very specifically. So you don't just say heart failure. It's probably, chronic mixed systolic and diastolic heart failure. That is a different diagnosis than heart failure. Heart failure in most systems does not risk adjust. It doesn't change the reimbursement. Patient has the condition, we just didn't say it right, and therefore didn't code it right. So number one, be specific in your documentation, and your physicians need to, and providers need to know, somebody needs to be looking over their shoulder to make sure that, doc, you just wrote heart failure. I know that doesn't, can we be more specific? The second thing that clinicians need to do is to show something about what we're doing. It's called MEET, and it's in I have a talk later on today about this. It's management, monitoring, evaluation, assessment, and/or treatment. We need to have some of those things of management, monitoring, evaluation, assessment, and/or treatment to show that we know they have heart failure, but what are you doing about it? They want to know that you're spending some time and thought on what are we doing. That includes a treatment plan. It does include medications, but just listing a medication is not enough. You actually need to, when are you going to recheck them? What medications you put them on, what you inform them about what happens if they're getting worse, when should they call or come back in. So a little bit of it's find the specific diagnoses and then document that. Then it can be documented well and specifically, and something about what you did for it, and then that can be coded and submitted, and then you won't get denials. It's kind of interesting how it works. In that middle box, it says something about pre-office visit preparations. You already heard about that, and annual wellness visits. Well, to understand that they've always been important, somebody should have gone through the chart before I saw the patient, and I have worked a lot of primary care, and said, hey, we've got these. They're here for more tests, or they're here for follow-up, or they're here for whatever. That should have always happened. That's even more important when you understand that Medicaid pays all of that risk-adjusted part. They're paying for the diagnoses, the specific diagnoses. They pay year by year. So they're paying throughout the month, but it's really, they're paying year by year, meaning that, and this happens in Medicare Advantage also, CMS in its infinite wisdom cures all diseases, all limbs grow back, all ostomies close, all the risk-adjusted conditions that a patient has goes away on January 1st. You actually have to see the patient once a year. And so now annual wellness visit is a little bit different than just checking some boxes. Yes, we asked them how they were doing. We asked them if they were smoking. We asked them if, check their weight, did this. No, we have to have an annual visit, and it might as well be included in an annual wellness visit that goes back in and dives in and re-documents each and every condition that they have, and documents our plan and our treatment of that, our management, our monitoring, our evaluation, our assessment. You don't have to do all of those and document all of those, but at least some of those. And, we should be thinking through those things anyway. So, wow, annual wellness visit, it really sort of takes on a new form and a new importance. While that pre-office visit preparation helps us in going, okay, so what did they have before? What they might have seen a consultant and there's a new diagnosis. By the way, it is okay to document that the patient now is being treated for, chronic diastolic congestive heart failure by Dr. Jones, the cardiologist. That's okay. That is a treatment plan, and knows when, knows the signs and symptoms of worsening. That's fine. It should probably be documented by everybody, because what we know by Marcy's audits is that a lot of stuff falls through the cracks in the floors. The cardiologist might have 5 different diagnoses and actually only recorded 1 or 2. So you've only seen 1 or 2, and unless you read the note, and then you go, oh, but they have other things that also. So what I'm telling you is that pre-office visit preparation, the annual wellness visits, have taken on a whole new meaning in trying to end up having appropriate use of our outpatient services. Trying to see some of the people that are sick today, and that whole scheduling thing gets really important. We have a client that left some space open. They were pretty busy clinics, so they saved a little space open for people if they felt poorly. They ended up with the lowest emergency department admission rate and the lowest hospital admission rate of any group in the country, because they kept a little space open. That's a little tricky, because you like to be busy, but you also, if your patient's just a little sick and needs to be seen today, you don't want them wandering into the emergency department, because number one, I don't think we provide as good of care as you do, because you know the patient. You have the patient's records. We're just shooting from the hip, and we are a lot more expensive. So try to limit the use of high-cost specialty services. I think that goes without saying. We always should have been. And we're trying to limit, unexpected readmissions. So that same group I told you about, they have a policy that they see every discharged patient of theirs within 36 hours. And I know that's hard to do, but they have the lowest readmission rate of any group in the country. I mean, they're the gold standard. It's hard to reach. And I understand that they have clinics with, 5 doctors and 2 nurse practitioners, and they have 7 clinics, and, they're set up for it. And you may not have that luxury, but if you can take some cliff notes from the whole concept of, we need to find all the diseases, take as good a care of them as possible, and keep our patients out of the hospital if at all possible. Next slide, please. So there are the 3 R's, which I'm not real big on the 3 R's, other than the fact that we've already been through who is covered, and you need to make sure that they're covered. And I know that that's part of the revenue cycle thing, which as a clinician, I'm just assuming somebody's figured out whether, who they belong to, who is paying this bill, and that's already done. What is valued? That's important to me, because it's quality, effectiveness, and efficiency. So the quality and the effectiveness are very important. The efficiency actually is, and are we doing a good job at keeping them out of the hospital? Are we providing a high level of care efficiently? So how is it valued? Well, it's interesting, because there are some payments for, if you do this thing, you can get paid, some money for connecting the dots on a specific function, a quality measure or something. There are payments per attributed member, but the real biggie, and where value-based reimbursement is going, is the next one, and that's with weights and thresholds. So all of risk adjustment reimbursement is weighted. Each disease is weighted. Each disease either has no weight, and because it's not a major disease, or if it's a disease that takes more care than just a runny nose does not risk adjust. But, chronic sinusitis, I believe, does. By the way, I'm not a coder. I've got really good coders that I work with, but I don't know everything that codes. What I know is that I need to write down specifically what the diagnosis is, and somebody who knows how to look that up can find the correct code to assign to it. And whether it risk adjusts or not, whether it affects reimbursement or not, I try not to worry about that. I just want to find the specific codes, but that is where value-based reimbursement is going to be all of Medicare Advantage by 2030. Medicaid's a few years behind, but it is coming like a freight train. As I told everybody yesterday, is that light at the end of the tunnel is a freight train. So we might as well get started down that path today. So there are other resources, health information portals, and there are analytics. So you heard some about analytics. What we like to do is look at charts and see what the doctors saw and documented and how that was coded, and how did it translate? Did the doctor use a sort of a general heart failure diagnosis that when really it was a more specific diagnosis? We learned all that from doing DRG work in inpatient. That's always been about the diagnosis codes, is that the way we train physicians is, we have educators, we can train the practitioners, but they also learn from their own mistakes. And so having somebody go in after the fact and say, or even before the fact, we do a fair amount of going in and the week before the patient's seen and say, especially people with chronic illnesses, and say, here's the things that need to be addressed when you see the patient next Wednesday. And that helps a lot. So that again is another way of getting that chart together. And excuse me. So there's more information there's so much information, but I try to look at it clinically, sort of simply, is find all the disease. Well, prevent what you can, find all the diseases, get the tests and consults you need, but the goal is to keep them out of the hospital. Some of them are going to have to go to the hospital, but take care of the ones that you can. If they have a minor acute problem, try to keep them out of the emergency department, try to keep them from being admitted. And if they do get admitted after they're discharged, please see them in a timely manner. It is amazing. I do a lot of that work, and it's amazing why people they get scared. They didn't understand their instructions. It's simple stuff. So they go back to the emergency department. And then a lot of times the emergency department goes, well, I guess they're still sick, so let's readmit them. Well, no, that could all be, you could stop all that just by literally seeing them after they've been discharged. So please put questions into the chat box. We're going to answer at the end. And thank you. So I think I'm doing this. Please, the team-centered approach is a key takeaway. Know who your contracts are, know your contracts, know what's out there. You might consider, as you're getting into new contracts, they're going to push new concepts onto you. We've watched the transition from fee-for-service to full risk contracts in Medicare Advantage. And there are a lot of groups that didn't understand how that was impacting them and what they needed to do about it. So you got to know your contracts and maybe get some help in developing those contracts, developing relationships with the payers. Interestingly, the payers get their money from the risk scores also. They want us to find everything. They want us to be specific and document it, and document it specifically so it can be coded specifically so the money comes in. It's kind of weird. I've never been on the same side with an insurance company, but now we are. It's kind of strange. IT infrastructure is critical. I can't speak if that's already been spoken to. I have to trust my IT people, and I ask them for reports all the time. Staffing, oh my gosh. Yet utilize your staff to the utmost extent that you can. They can take on more. They can do more. And there are specific things like in helping prepare that chart, but just gathering the demographics and making sure all the I's are dotted and T's are crossed. And basically everything and everyone matters. This is a game changer. They have changed how we do business by a reimbursement structure change that we're trying to do the transformation to. But my bottom line is it actually provides a higher quality. It gets us more focused.
Todd, I'm so sorry to interrupt, but I know we only have about 3 minutes left.
Oh my gosh, I didn't know that.
Fantastic points. Here's what I want to say, everyone. Todd is joining us later. So if you want to hear more about coding, about perspective of the medical side with Dr. Todd and others, please join us this afternoon. We do have a great survey that we want to get your feedback. So if you could please fill that out, we would really appreciate it. It's going to help us as we think about future technical assistance for this initiative. So please fill that out. And then also, I hope we put it into chat. We have a great website with lots of materials on revenue cycle, finance, legal, different things that we would encourage you all to go to as a resource. So please go on that. Thank you so much, Keon. And we appreciate your time today. We have 3 minutes, so let's open it up if folks have any questions, if that's okay with our presenters.
Fire away. And yes, please join us from 1 to 3. We have some more.
Oh, we have a quiet group. You can put it in chat if you don't want to come off mute, but we're happy to answer any questions if folks have them. Right, well, I guess we don't have any questions, so
We may
Brianna, do
have
you
given
wanna
them
take
so
us
much
home? Go ahead.
information. May take a little
Great.
while to digest.
I guess, Caitlin, I'm just going to chime in. So again, please complete the evaluation. I dropped the link. Again, most important, the evaluation survey is required if you're requesting for continuing education credits. You also receive an email later in the day today. If for some reason you missed the link that I dropped, you'll receive the link again. Please join us again from 1 to 3 if you want to hear more about Todd and coding. And then again, the recording and slide decks will be available on the Medicaid Business Transformation DC webpage in the next few days. I dropped the link for that as well earlier. And if you haven't done so already, please sign up for our newsletter for the Integrated Care DC newsletter to stay up to date on the district's initiatives, resources, and technical assistance opportunities. And I guess I can chime in at the end. So here's the contact information for today's presenters. Please reach out to the presenters if you have any additional questions after this session. Guess I can say that this concludes today's session. So thank you guys again for participating in the Medicaid Business Transformation DC Value-Based Payment Learning Collaborative. And we hope you join us later today from 1 to 3. Thank you so much, everyone. Have a great day.
Thank you all.
Thanks, Keon.
Thanks, everyone.